In this lecture, we will learn how to approach to a neonate with jaundice, how you can differentiate between the different causes of neonatal jaundice, and how you can reach the most probable diagnosis and how you will manage each condition. But at first, we must know the normal metabolic pathway of bilirubin. Bilirubin is produced by the breakdown of hemoglobin inside the reticuloendothelial system in the liver and spleen. Actually, 1 gram of hemoglobin produces 35 milligram of bilirubin. This bilirubin is an conjugated type, indirect type, which is water insoluble. So it must be bounded to albumin to transport it into the liver. 1 gram of albumin can bind 8 milligram of bilirubin. When unconjugated bilirubin level exceeds or exceeds the ability of blood albumin, it accumulates inside the blood and crosses the blood-brain barrier to produce a condition called a kernicterus. Kernicterus will appears when the unconjugated bilirubin level inside the blood is more than 25 milligram per deciliter in full-term baby. But in premature sepsis, meningitis, the kernicterus will appear in a low level less than 20 milligram per deciliter. This unconjugated bilirubin, which is bound to albumin inside the liver, undergo a conjugation process conjugated to glucuronic acid by an enzyme called glucuroneal transferase to produce a conjugated type of bilirubin, which is characterized by water solubility and lipid insoluble, transported through the biliary tract to reach the intestine, in which it's breaks down into stercobilinogen, urobilinogen, and unconjugated bilirubin, which enters in the enterohepatic circulation to be remetabolized inside the liver. Stercobilinogen is responsible of the brown color of stool. Urobilinogen transported by the blood to be excreted with urine. Our approach depends on the time of appearance of jaundice. Either it appears in the first week of life, or it appears after the first 2 weeks of life, or persistent after the first 1 week, or persistent for more than 2 weeks. Early onset jaundice that occurs in the first week of life may be due to acute hemolysis, physiological jaundice, or neonatal septicemia. In the condition of acute hemolysis, the jaundice is so severe and appears just after birth or in the first day of life. As a general rule, any jaundice that appears in the first day of life is always pathological. In acute hemolysis, the general condition of the baby or the newborn is poorly ill, poor suckling power and poor activity, and the jaundice is severe, associated with severe anemia. Hemoglobin level may reach below 6 grams per deciliter. Causes of acute hemolysis. Acute hemolysis may be caused by Rh incompatibility, ABO incompatibility, or rarely by large cephal hematoma or glucose 6-phosphate dehydrogenase deficiency. We will focus on the most common causes, which are ABO incompatibility and Rh incompatibility. ABO incompatibility become more common than Rh incompatibility due to the prophylactic anti-Rh antibodies that given to the mother just after birth, or prophylactic during pregnancy. ABO incompatibility with neonatal hemolysis develops only if the mother has IgG antibodies from a previous exposure to A or B antigens. These IgG antibodies cross the placenta by active transport and affect the fetus or newborn. Sensitization of the mother to fetal antigen may have occurred by previous transfusion or by conditions of pregnancy that result in transfer of fetal erythrocyte into the maternal circulation. ABO incompatibility usually cause anemia, but a mild anemia and hemoglobin level does not reach below 6 mg per deciliter. In contrast with Rh incompatibility, which occurs when Rh negative mother has received a blood with Rh positive, either by blood transfusion or by first pregnancy with Rh positive fetus. This sensitized mother now has Rh antibodies. If she becomes pregnant with Rh with second pregnancy having Rh positive, these antibodies will attack the Rh antigen of the newborn, causing severe hemolysis, edema, pallor, hepatosplenomegaly, and this all is called hydrops fetalis. The second cause of early onset neonatal jaundice is physiological jaundice. Actually, physiological jaundice is the most common cause of neonatal jaundice. Usually it appears at the second or third day of life of the newborn. The cause of physiological jaundice, it may be due to the immaturity of the enzymes inside the liver, specifically the glucuroneal transferase enzyme, which is responsible of conjugation of bilirubin with glucuronic acid. Compared with adults, newborns have a twofold or threefold greater rate of bilirubin production, range from 6 to 10 mg per kg per day, versus 3 mg per kg per day in adult. This increased production is caused in part by an increased RBC mass and a shortened erythrocyte lifespan of 70 to 90 days compared with the 120-day erythrocyte lifespan in adults. It usually subsides within 1 week of onset. Anemia is absent and the general condition is intact with good activity and suckling power. Third cause is neonatal septicemia. Usually appears between the 4th and 7th day or later, but if it occurs late, usually it becomes moderate in severity. Anemia, if present, is usually not severe. The most important clinical signs are the markedly affected general condition. The baby is not doing well with lethargy, poor suckling, vomiting, fever, or hypothermia. In severe cases, serious complications may occur as septic shock, renal failure, and disseminated intravascular coagulation. Laboratory investigations will show us a high total WBC count may exceed 30,000 per millimeter, and erythrocyte sedimentation rate exceed 15 millimeter in the first hour. CO-active protein usually above 20 mg per liter. A rapid recap of neonatal jaundice early onset. The most common and important three causes are acute hemolysis, physiological jaundice, neonatal septicemia. We will compare between them according to the onset and severity of the jaundice, presence and absence of anemia, and the general condition of the newborn. In acute hemolysis, the onset usually immediately after birth or just in the first day of life. Physiological jaundice usually appears at the second or third day. Neonatal septicemia occurs from the 4th to the 7th day of life. Anemia in acute hemolysis is so severe, hemoglobin levels may reach below 6 mg per deciliter. 6 gram per deciliter. In physiological jaundice, anemia is absent or mild. Neonatal septicemia, anemia may occur but is moderate. The general condition of the newborn in acute hemolysis is very poor as a neonatal septicemia, but the condition of neonatal septicemia, the patient is feverish or hypothermic, lethargic, poor suckling power. We can differentiate between them just from the laboratory investigations such as WBC count, hemoglobin levels, and conjugated or unconjugated hyperbilirubinemia.